Recording in progress.
Welcome to week 7. We literally are 4 weeks away from cumulative exam, 2-week break, and then getting ready for mod 3. Okay, so it's going to be coming fast. So the questions that I grabbed from last week were 2 that I saw that was missed, and I kind of want to go over them. Okay, now the question was, blank energy is created when electricity is transformed into mechanical energy to high frequency vibration and friction. So, of course, we have laser, ultrasonic, cold thermal, and then electromagnetic. Okay. Now, what type of energy do we kind of start with? Like from the beginning, like what are we starting with? Right, exactly, electric. Now, what does electric energy transform into? It's almost like a hierarchy. Right, mechanical. So, mechanical energy. Now, what does that mechanical energy create? I'll give you a hint. It's right. So, you have your high frequency vibration and kind of like friction. So we're looking at the 2 surgical effects that we get from that we use in the operating room. Like the 2 main ones that we are constantly using. We're either going to kind of go through the skin or um, or stop bleeding. So we're either going to try to cut or coagulate, or cut and coagulation. Okay. Now, when we look at this question again, ultrasonic energy is created when electricity is transformed into mechanical energy to high frequency vibration and then that friction. That ultrasonic instrument will simultaneously cut and coagulate tissue by just transmitting the ultrasonic wave energy through, like, the forceps that we use. We have scissors that are used and blades. So that's why if you see this concept again, you'll look and you'll be like, okay, wait a minute. We're looking for ultrasonic in energy. Does that help break down that concept? Like if you guys were to see it again? Okay. And then I grabbed another one because I wanted to make sure that we kind of have 2. We're going to do this kind of the same way. Okay. The question, the electrical charge at any given time between 2 points is referred to as, now, of course, we know the answer, right? But the other choices, current, volts, watts, and amperes. Okay. Now, are we talking about flow of electrons, resistance, power, or pressure this time? What do you think? Right. Pressure. Pressure in electricity. Pressure is called voltage, measured in volts. So if amps are the flow of electrons, then volts are the push behind the flow. When we think clinically, if there's no voltage, can current move through the circuit? There's nothing to help it. Right, it can't, right? No movement, nothing can happen. Now, this is why kind of understanding voltage matters when we're using our particular surgical equipment in the operating room. Okay, so keep in mind that in this case, the correct answer is again volts. Okay, real world example, we have that 9V battery. It has potential difference. You always notice there's a positive and a negative. Okay, you have your terminals. So if you guys want to take a screenshot, you guys can use this as a resource as you guys are studying and preparing for your cumulative exam. And I didn't do that for the last one, so I will reverse in like a second and give you guys that too. So let me go back one. So if you didn't get a chance to screenshot this one, go ahead. Again, just use this as a resource because it can come back around for that cumulative exam. Because remember, that cumulative exam is from weeks 1 through week 10. And I want y'all to feel really comfortable no matter what you see. Okay. Are we good? Okay. um, this one's a little bit easier. I feel like this week. Um, because you can kind of relate to it a lot better, being that we've all heard about different disasters, right? Like we all know what hurricanes are, tornadoes, earthquakes, being in California, and different things. So this one I feel like will be kind of like a little breather a little bit as we gear up. Okay. And I say that's because in week 1, it was who I'm becoming. Week 2, communication and teamwork. Week 3, we talked about medical legal responsibility. 4, we got into environmental hazards. And last week was pretty heavy because we were talking about energy sources and safety. So we're actually putting it all together a little bit and kind of following this journey of building our foundation. Okay. So this week, you're going to likely see things like still communication. You're still going to be looking at legal things. We're definitely going to be looking at hazards and identifying things. But up until now, most of our discussions have assumed something important: control, right? Like we're controlling communication, we're controlling the hazards. There's a scheduled procedure. We have a area that's prepared. We know what our patients got going on. We can kind of predict things based on their allergies. But disaster responses removes predictability, okay? But it does not remove our responsibility. So I want you to kind of think of this. You're in the operating room, you're scrubbed in, you've been in tech for about a year now, right? Halfway through your case, suddenly you hear an overhead announcement: mass casualty incident, activate disaster protocol. Now, what changes first? Staffing, room turnover, priorities, stress? We still have to communicate, but now we're adding on something like triage. But then here's a deeper question: does sterile technique change? What do you guys think? Does sterile technique change? No, right? We're not going to change anything. The standard doesn't disappear because of a crisis. They do get harder to maintain, but we still do it. Okay? Now, disaster response is where that question actually becomes real. Professionalism is easiest when things are calm, you have an idea, you see the schedule, you know what room you're going to be in. You're like, okay, I'm scheduled for 10 cases in my room, but I'm an ENT. So those 10 cases we're doing a bunch of ear tubes and tonsils. They're about 30-minute to 45-minute tops. So you're like, all right, this is a pretty smooth day with the doctor that I like. It's not going to be those days. It's going to be tested when they're not calm and easy. We look at tension, right? In disasters, not everyone can go to surgery immediately. So who decides who goes first? How do you feel about that, right? Like, oh my goodness. Those are things that weigh heavy, right? Because you see patients coming in and out, and you're seeing some are put on hold and some are coming straight back to your room. Today, we're going to talk about systems, not necessarily emotions, because disaster management relies on structure, not for us to panic. Okay? Let's see. Okay, so I did get a question. I'm going to follow back up on that one when we roll back. Okay, so I do see that there is a question um, about the missed concepts. Okay, so I want to kind of get through this and then I will definitely go back around. So I'll make sure I go that. So thank you for reminding me. All right, so we get into disasters. Okay, and I want you to notice something. We're not memorizing the goals, right? They are kind of like our thinking goals. Like, this is what we have to kind of go with. We get to discuss. Very first one. How does discuss, or what does, when you see the word discuss, what does that require in a disaster? Anything. Like, what does it mean to you when you see the word, okay, we're going to discuss some stuff? Okay. Exactly. Communication, plan, speaking, listening. But we're going to be sharing our ideas. Most definitely. The first focus says that for a reason. The unique responsibilities and scope of the ST during a mass casualty event is a little bit unique. Okay. Now, do you think your role gets bigger or smaller in a disaster? There is no wrong or right answer. Just what do you think? Do you think it could be kind of a mix of both? The thing I want you to remember, kind of, is your role will kind of expand, but not in scope. Okay. Our role doesn't expand beyond our scope, but our awareness kind of has to, depending on what's going on. So think of it this way. You got multiple trauma patients arriving at once. There's certain things that we're going to be looking at: room setup, instrument readiness. We're going to be assisting with turnover, something that we normally don't do if you're at a big hospital. We have turnover staff. Communication is going to be extremely important. And we're going to really jump into, after it's discussed, is kind of analyzing. We look at deeper thinking, understanding how things work. When we're learning how it prevents chaos. Remember, emotions are already high, stress levels are high, right? If everyone in a hospital just did what they felt was right during a disaster, is it possible that chaos could just run rampant, right? Yeah, like, oh, I feel like sitting here and watching everybody, or I feel like being the surgeon. Wait. You work at admin. What do you mean you feel like being the surgeon, right? Well, they just felt like it. So confusion could happen, delays, definitely risk. Okay. And then we look at recognizing different things: ethical, logistics, triage challenges. In a disaster, not everyone receives immediate care. That's a big one. So, how do you think that feels for healthcare providers that are at ground zero, right? Having to tag certain patients. Some patients do not get moved. So, we're not solving that yet, but we are kind of looking at the weight of the responsibility of this. So, we define the threat. I want you to look at this image before we even talk. And as you're looking at it, I want you to notice first think about the first thing that you notice. Okay. You have three circles and they overlap. Different categories, all hazard approach. We tend to think of disasters as one type of event, but healthcare systems do not prepare us for just one thing. They prepare using what's called that all hazard approach. Okay. Natural: hurricanes, pandemics, earthquakes. Man made, or technological. So you look at chemical spills, explosions, terrorism. Internal facility. Now, a power failure or a fire. Notice something important. Internal disasters do not require the outside world to collapse. Sometimes the crisis is inside of the building. Now, which of these three do you think would feel the most chaotic inside the operating room? Natural, man-made, or internal? We look at, and there are no wrong answers, just so you guys know. It's just kind of like what you see, what you feel. Okay, putting yourself in that situation. We look at the volume of patients, infrastructure damage, communication breakdowns, contamination risks. Now let's talk about this scenario, okay? We look at our preparation, okay? How does your preparation change if you have a 48-hour warning for a hurricane versus 0 warnings in an explosion? So you have 2-day notice, okay? What can a hospital do in advance? They can cancel elective cases. They can prepare. Yes. What else can they do? What do you think they would do with patients that are stable? Do you think they would keep them or try to discharge them? Move them, right? What about our equipment? Remember, you've got a 48-hour notice. The hurricane's coming. Think about all the things that could be happening in that 48-hour window. Make sure they work, right? What about think about what could happen during a hurricane. Like windows will get open, things can be moved, flooding, supplies, securing equipment, most definitely. Maintenance logged, yes. They may have to adjust us as staff. You're thinking like me. Stock up of supplies and make sure important equipment is ready, specifically that ones that are needed in case of power outages. And you just hit the biggest one, fuel generators. So making sure that that equipment is ready to go. Now, as CSTs, we may be asked to prepare inventory trays or prepare emergency instrument sets that we normally wouldn't have. We may be asked to help reorganize the storage or even review emergency protocols during that 48-hour preparation window. Okay. So now let's look at the opposite side. No warning. Multiple trauma patients are en route. What happens first in this instance? Remember, we don't have the same 2-day or 48-hour window. What skills from week 2 become critical immediately? You guys were saying it earlier. Something that has to be tight. Communication, yes. Because chaos increases when communication decreases. But does sterile technique change in either scenario? No, right? Does scope of practice change? Also no. The only thing that changes is pace, volume, that like emotional intensity, and prioritization. But there's an ethical layer. In a 0 warning event, if 5 patients need surgery and only 2 ORs are available, who decides? Just want something for you to kind of think about because that happens. Who's more critical? That is a choice. That is definitely one of the factors that gets thrown into it. Okay? Now, our role as the CST, I want you to look at the image. Okay? You see a sterile field, there's instruments, there's a boundary. We have a setup. Notice the dotted line, the sterile field boundary. In a disaster, that boundary still exists. I want you to know that, okay? So here's our situation. We're scrubbed in mid-procedure. We're doing a routine laparoscopic cholecystectomy. Okay, we're just removing the gallbladder. Nothing crazy. Suddenly, overhead announcement. Disaster code activated. What is your immediate priority in the operating room? I have seen concepts thrown at you from this week where they throw different scenarios and they're asking you to think about you, you're there, you're in the role. What is your first priority? Things I want you to look at. We always come back to patient safety, right? But we're still going to maintain that sterile field. We're going to still try to secure instruments. A while ago, actually a couple years ago, I was scrubbed in on a Saturday during an earthquake. And when the building is shaking and our patient was already intubated, okay? So my goal or my job was to maintain sterility, making sure that nothing, no debris or anything fell on my field. My surgeon and anesthesia was making sure airway was good to go, and our circulator was kind of like going over the room. Was not a big earthquake, but still, right? Like you're still maintaining the sterile field, patient safety, and making sure that for us, our instruments are still secure. Okay. Now, in crisis, professionalism doesn't abandon the patient on the table. How do you know it's still sterile? Great question. We don't, right? It's one of those where we look to make sure that there's nothing visible, and then because we were already in the case, we were actually almost done with the case. Neither here nor there, because it could be mid case, right? We kind of do what we can, making sure that like visibly nothing, and then we do everything. It's not prophylactic at this point. It's just making sure that we're closely monitoring the patient. I think our patient also did receive antibiotics post-operatively as well, just because of the nature of that particular case. That's not one where we could like we didn't know the earthquake was going to happen, number one, and then two, we're already mid case. But that's an excellent question, and you're already thinking like, what would you do in that situation? Great question. Does that make sense to everybody though? Like we're mid case. Okay. Now, I love this because it kind of goes into the next point. In a crisis, we are not going to abandon our patient. We weren't going to be like, oh my goodness, it's earthquake. Peace out. Good luck, right? We're not going to do that. We're going to make sure that we do not abandon our patient and we're going to stay there. Our first responsibility remains that patient that's in front of us. Now, depending on your role, that will look different, right? We were scrubbed in, so we are maintaining sterility. We're maintaining our field. We are still protecting the patient, and we're protecting the patient by protecting our field, okay? Now, we always have to ask what could go wrong in this moment if our focus shifts just a little bit. We're definitely breaking sterile field. We could have a miscount. There could be an injury, contamination, or, okay, let's hurry up and try to rush the closure. Distraction increases risk. Now let's assume the case is safely concluded. Okay, patient stable. Now we shift to getting the room turned over, getting our instruments processed, supply management. Sometimes we may need, or one of us that's free, a lot of times you may be a floater, you can help with transport of patients. In disaster response, we as CSTs often support throughout the entire process, not by necessarily expanding our scope, right? Like we're not in there doing heart surgery, but we are increasing efficiency. Now we get to the third question. What tasks are strictly outside our scope, even in a disaster? What do you think things that no matter what, we're still not going to be doing? Right. We're still not triaging. We're still not prescribing medications. We're still not diagnosing patients. Like, we're not doing that, right? Disasters do not expand our licensure. Scope does not flex under pressure. And this is important because we go back to medical legal aspects, legal protection, patient safety, role clarity. There's a structure for the systems in place for a reason. Remember week 3. Accountability doesn't disappear during a crisis. If anything, documentation and adherence to scope become even more critical. Now, if you heard mass casualty overhead while you're scrubbed in, what emotion do you think would hit you first? For me, I'm going to be a little like, okay, adrenaline is going to start pumping, a little bit anxiety. Um, that's just me. What about you? Fear, most definitely. Panic, then real, yeah, right? Like, oh, this is about to go down for real. This is it. Scared. And anxious. Exactly. And that's all normal. Preparation does prevent panic, but your emotions are still going to be there, and that's okay. Okay? In a disaster, you're not the loudest voice in the room. You are the steady hands. Your job is not to do everything, but to do our role exceptionally well. And that's what keeps systems functional. Does that make sense before we move on? Okay. Now, I want you to kind of look and see how the communication and command structure is laid out. We have a pyramid shape. One person, the incident commander, is at the top. And then you have your sections underneath. And then there's clear division. Okay? This is structure. And structure, again, remember, prevents chaos. So if everyone is in charge, is anyone in charge? It's almost like a bunch of chiefs in the kitchen. Well, who's the main chief, right? They're not. There's no one. That has too many people and chaos can occur. During disasters, hospitals activate what's called the Incident Command System. You will see some concepts on this week. Or you may just see ICS, but just know ICS is Incident Command System. Okay? Specifically in hospitals, it becomes Hospital Incident Command Systems, or HICS. So we get into their purpose. Their purpose is to organize through clear hierarchy. So we get to that incident commander at top. Just one. That's called unity of command. Now, we have a unity of command. It matters. It matters during a crisis because, one, it's going to prevent confusion. Two, it prevents conflicting orders. Like, one person said this, now I'm hearing this. And then we get to faster decisions, clear accountability. In a crisis, believe it or not, when people are debating, that's going to slow the response, which means now we have patients that aren't being cared for properly or in a timely manner. In week 2, we talked about communication and teamwork, and you see how I'm bringing it forth so you can have an idea of how these same concepts from week 1 through 4 will show up on your cumulative exam. Okay, so we talked about communication and teamwork in week 2. Teamwork is not everyone talking at once. It's okay, we have direction that is coordinated. Organization, we look at operations, hands on response. People are out there on the field, bandaging wounds, giving CPR in some cases, tagging, where you've got red, black, yellow, and green. Okay? You have your planning. You got someone forecasting, strategizing, seeing how to move and when to move, going along with just logistics. How much supplies do we have immediately that we can use for our patients? How much equipment? Who do we have on staff, and what are their credentials? What can they do? We still got to talk about finance because we're tracking the costs. We're tracking our resources. Now, for us, we look at which branch directly impacts us as CSTs the most, because we're going to be touched by all of this. But looking at what I just went over, and I'll give you a hint, usually two that affect us a little bit more than the others. Which one do you think it is? Or which two do you think it is? Operations, planning, logistics, or finance? Operations, definitely. Planning can. Yes. Operations and logistics. Planning can, but logistics hits us more. So the key word here is the most. You will see questions like that more on the final exam. You may get some sprinkled this week, but you're looking for those triggers. Most, always, never. Okay, so in this case, operations and logistics, even though planning is still a good answer, but that keyword is the most. Okay, now, of course, in disasters, logistics becomes very important. We cannot operate without supplies, right? Like, our hands are tied. We only have so many fingers. Like, we can kind of pinch off a vessel if we're told, but then again, that's not going to be sustainable long term. But here's a conflict. If a surgeon gives you an order that conflicts with the incident commander, now we're like, oh my goodness, who do we follow? That question was meant to be uncomfortable, okay? Because we're trying to follow the hospital chain of command. We're looking at escalating through proper channels, not independently deciding on, okay, well, I'm going to just listen to this person because they're here. Okay? Again, now we're talking about a skill from week 3 that protects us here. Documentation, scope, but following policy. Other things to think about. Technology sometimes, most often, will fail. So what happens if cell phones fail or radios fail? We have backup systems. Of course, we're going to be very dependent on runners, and sometimes we could be chosen as a runner, meaning that we're running back and forth through the different stations. Paper documentation is going to come back, and there are going to have pre-established protocols. Communication can fail, which can lead to patient care being delayed, most definitely. Yes. This is why we have these systems in place. This is why sometimes it feels redundant, because communication failure honestly is predictable. Like during a hurricane, we can most definitely assume that a power line is going to go down, right? Fiber wire may not work. Satellite may not be able to be as clear during a hurricane. Now, in crisis, people often revert to personality. But command structure is not about personality. It's about role clarity. As a CST, we are not making the system level decisions, right? But we are operating with coordinated structure. And disaster response is not where, you know, everyone's trying to be that hero, right? It is where everyone is looking at coordination. It's discipline. It's understanding that command structure. This is what keeps us from kind of like that term, like stepping out of our lane, so to speak. Okay. Now, We get into triage and prioritization. And I'll be honest, I sometimes get these confused, but let me explain why. In the military, we learn it differently because our job is differently, right? Like when I'm looking at different colors, for me, we don't give the most critical person to the operating room first. We get the ones that, and I'm not going to confuse you, but just know sometimes I get these confused because in the military we're trained triage differently. Okay, so I need you guys to really make sure you're reading this particular section because I don't want to confuse you, and that's because I'm still trying to like make sure that I say them correctly. Okay, now the colors: green, yellow, red, and black. Okay, so we have the tags. We have our priority levels. We have our emergency classifications. Okay, this is triage. So we get to the logic shift from sickest first to greatest good for greatest number. Okay, sickest first to greatest good for greatest number. In a normal emergency room setting, the sickest patient is treated first. That feels just morally correct, right? Like, okay, we're going to get that person in. But in mass casualty events, that logic changes. Why do you think that shift happens? Why are we not bringing in the sickest person now first? Think about the resources. More, yes. I'm telling you, you're like right there. More resources can be used for someone who may not make it, right? Think about space in the operating room, blood supply. And then you already know that staff may be limited or spread thin. Disaster triage is about survivability and resource allocation. So let's say you have one operating room available, but two patients arrive. Patient A, severe injuries, very low chance of survival, even with surgery. Patient B, serious injuries, high chance of survival with immediate surgery. Who goes first? Patient A or patient B? Luckily for us, um, we're not making the harder decisions like that. Like we already kind of in our mind know, okay, we see the two patients, we kind of know what choice is going to be made, so then we can start prepping, right? But the person that is making that decision, your triage officer, your trauma surgeon, incident command. Understanding triage does not mean owning, or actually I should say understanding triage does not mean owning the decision. Okay? Now, let's transition to this black tag over here. There are some ethical difficulties of assigning a black tag. Some things that kind of go through the mind, right? Withholding care. There's an emotional burden. We think of the family impact, moral distress. In disaster response, a black tag does not mean someone is unworthy of care. It means resources are redirected to maximize survival overall. Now, I want you to answer honestly in your own mind. You do not have to answer here because this is highly personal, okay? Could you emotionally handle being part of a system that does not treat everyone immediately? Again, you do not have to show anything. It's just kind of like for you to think, not to overwhelm you, but to let you know that that's normal. We experience moral stress during disasters. We're human. We put on our clothes like everyone else. Of course, we feel it. That's real. Preparation includes psychological readiness, where we ask these tough questions when we're not in those situations, so that if we do become in those situations, we do have a baseline to go back to. This is why we talked about incident command. Triage decisions are system based, they're not personal. As a CST, our role during triage activation is, again, we're preparing assigned operating rooms. We are making sure that the instruments are ready. We are maintaining sterile integrity. We are supporting throughout the entire incident. Okay? But we're not making it, we're there. Disaster ethics are uncomfortable, y'all. But discomfort does not mean dysfunction. It means responsibility. And our goal is going to always be the same. Like, we're preserving life with the resources that we have available. Does that make sense? Okay, again, you guys, make sure you read and go through and have a good understanding on exactly how the chapter describes these tags: green, yellow, red, and most definitely black. Okay. Now, how do we manage sterile supplies when we don't know when the next delivery is coming? In a regular day in the operating room, we assume something very important. And I said assume because we do. What we think about is that our instruments are going to be there. We can reorder. Oh, you know what? I'm not worried about it because central processing department can turn over our instrument trays. And if that is worse, we can get on the phone and call the vendor, and the vendor can deliver them to us. But disaster planning challenges those assumptions, right? Our behavior changes when we do not know when the next shipment is coming. So we start to do a couple things. We're going to start conserving. We're going to track more carefully. We're definitely going to avoid wasting anything. And now we're prioritizing the use of certain items. What week 4 concept, if you guys remember, connects here? And you can type in yes or no. What about environmental awareness? Or hazard management, right? And don't forget risk prevention, because waste also becomes a risk. All right, imagine this. You're in your operating room and all of a sudden you hear that announcement. Case volumes triples. When you first started your day, let's say you're at a 16-room hospital. My hospital's 16, that's why I'm saying that. And we normally can go through 75 to 150 cases easily, okay? But then we have mass casualty, and now that has tripled. Instead of 150, we are now looking at 450 cases, right? Every room is allocated. Even the rooms that we usually keep open for just trauma. All 16 rooms, and room 16 is our heart room, but that's got to be allocated too. So all of those rooms are allocated with 450 cases, okay? Supply trucks are now delayed. Of course, SPD, sterile processing, is definitely overwhelmed. But what becomes critical? What do you think are going to be some of the important things that now, with this new 450 caseload and our supply trucks being delayed, are we going to be thinking about? Inventory. We know SPD is overwhelmed. We're still going to talk to them. We're going to talk to them, see where they are in the process. We're definitely not going to just be throwing 16 cases at a time in. we've got to prioritize. And we're going to avoid unnecessarily opening our supplies. Opening supplies just in case becomes something that we can't afford in this particular scenario. Has anyone ever heard of a push pack before? Kinda, yes, no? No? Okay. A push pack is a pre-assembled supply package designed to support immediate response during like a high volume trauma situation. And depending on your facility, they may have certain ones. So like for us, our heart team has their own, we don't necessarily call it push pack, but we have like emergency pack, but that's what it is. So we have some just for hearts. We have some like if we have an emergency cranie, there's a pack ready to go. If we have an IM nail, so like femoral nails are emergencies because if that femoral bone, you don't want it to cut off the femoral artery, patient can bleed out. So we have a pack just for that and so on and so on. Okay. What it does is it just allows for faster kind of like deployment, or we get the room ready with just the standardized material, just the things to kind of save that life, save the patient's life. Okay. Now, some of the things to kind of think about as to why these standardizations matter even more so during a disaster response. Think about how efficient that is. Like now we're not going around trying to find certain sutures because we do pull certain sutures for those cases too, based on it. Like for cranies, we're going to have certain things specifically for the cranie, the drapes, gloves. We'll have a couple different gowns, just different things ready to go. Okay. Less decision fatigue because now you're not trying to remember like, oh my goodness, what else do I need for this emergency case? Which also helps with reduction of errors. Okay. And it does allow us to faster setups, and seconds matter. Okay. Now, with instrument processing pressure, that's a whole nother ball game. You got to think, you got 450 cases on the board. Okay. 16 rooms. So keep that in mind. 16 rooms. Now we're looking at faster turnover. Anyone that's not scrubbed into a room, even if you're a floater, if you're not running right, if you're not a runner, meaning taking things to different rooms at that time, all hands on deck to turn over these rooms. You may have extended shifts. So you may be a 3 to 11 person. Well, now you're no longer 3 to 11. You may need to be extended to a little bit longer. Protocols for counting are going to be strict no matter what. But we're making sure that we are double counting because we're moving so fast, okay? And again, we're still communicating with SPD because we already know how overwhelmed they are. So here's the question. We know that SPD, Central Processing Department, is overwhelmed. Does sterilization protocol change because the volume increases? Like, is there anything we're going to do different? No, right, Maddie? We're not. Standards do not relax under pressure. Now, which branch, bring it back, of ICS handles supply strain? Remember those branches? Which branch of ICS handles supply strain? Strain. Yes, logistics. We cannot perform surgery without an infrastructure. Like we can't do anything if our instruments aren't there. We'll all be in the operating room just looking like, want to help, okay? But we still got to throw in that ethical layer, right? If we run low on certain instrument sets, now we have to think about who decides which cases get it. 16 rooms. We can take out the heart room because their instruments are going to be different. We'll take out the cranie because cranies will be different. We'll even throw out ortho, okay, because ortho has specialty as well. So that leaves you with a couple general cases. A lot of times it's going to be a lot of general. So let's say we've got 6 rooms doing general cases. Okay, realistic. We're down to 2 general sets left. Who gets the next one? Okay. Those are things that will be kind of like be thrown back to those individuals in charge, looking at logistically, what do we do? How is this so far? Doing in real scenarios? Does this kind of help connecting the dots a little bit? Okay. So we get into safety, accountability, and professionalism. We look at the shield, okay? Protection, the cross, safety. Disaster response isn't about just saving lives, saving patients. It's also about us. We're trying to protect the team, okay? So with team accountability right up at the top, it's the very first thing you see. We're owning our role. We're definitely going to be following protocol. We're speaking up, but we're also going to be supporting each other. All 13 of us in here today, we're a team. We're going to be the trauma team, right? We've been doing this for the last 50 minutes, right? We're the team. Calm, believe it or not, is contagious, and so is chaos. Trust me. I have experienced it. You will be in cases and you may be the calm that calms the room. It can happen. All right. But let's talk about personal safety. You can't help others if you're injured. Fatigue will increase errors. Also, exposure risk. Disaster does not eliminate whether we put on our PPE or not. It does not eliminate breaks. Exhausted professionals make preventable mistakes. That's true. Now, when I want you to kind of think of it this way. When you're on an airplane and let's say the oxygen mask deploy, right, for whatever reason. And let's say you're with like a small child or another person that can't put theirs on. Do you put your mask on first or theirs? Kind of that same idea, right? You put yours on and then you can put theirs on. Because the theory is like, let's say you put theirs on and then you pass out and they can't help you anyway, right? So kind of like that same principle. If you're compromised, you become another patient. Mental clarity really protects the sterile field. So furniture factory explosion. Okay. You're asleep. Doing your just like whoop to do. But you're on call. The phone rings. Explosion and fire at a chemical warehouse. 35 burn victims incoming. 8 need immediate intubation. The hospital, HICS, has been activated. This is not theoretical anymore. You're in it. Questions. Do you have a go bag? What would be in it? You may have scrubs, not necessarily scrubs are there, your badge, water, snacks, because we get hungry, okay? Phone charger, your PPE, hair ties, medications if you need them. A prepared professional, you're going to be thinking before the call comes in. You'll have it, especially if you're on that team. All right? Your mindset is calm, you're focused, you're like physically ready. You have that mental clarity. So you get to the hospital, you go to the operating room, you may go to your supervisor, you may go to the command center or the labor pool to see where they have allocated you. You're reporting to your command center, okay? Your designated supervisor. You may see that comment, that concept somewhere, okay? Command center, designated supervisor. This is very important because we're looking at coordination. We're trying to avoid duplication. We're looking at safety and role clarity. Now, you're in the operating room. Burn debridement cases are incoming. Remember, there's 35. 16 room OR. Supplies are low. We're confirming instrument sets. We're coordinating. We're on the phone with SPD. We're using standardized burn trays. We're trying not to open anything unnecessarily, and we're communicating what we need at the moment in our operating room. We're looking at logistics. We're looking at resource conservation and everything we have and potentially may need. Now, remember this, not every burn victim will go to surgery immediately. Think about how that impacts the OR flow. Okay? So, kind of brought it together. Now, our quote of the week was a little bit later. Your present circumstances do not determine where you can go, they merely determine where you start. Think about that furniture factory explosion. The hospital did not choose that event, the timing, the 35 patients, the supply strain. That was their starting point. But what determined the outcome? The structure, command system, teamwork, preparation, and above all, our 13 members here professionalism. The circumstances set the stage, but our response determined the direction. Okay? This week, I do have a little Kahoot for you guys that I'm going to share. It is available until 15 June. That's the longest it will let me do it for. But I'm going to put it in the chat for everyone here. Again, you have till 15 June to use it just as an additional resources, especially as the final is coming up. What I will try to do is the earlier Kahoots, I will try to kind of extend that time if it should let me do it, so that you'll have all of them just as additional resources. The questions on there are directly from this week's chapter. Okay. Now, before we kind of get on the closing, I wanted to get to that question that I was asked. Okay, for the second commonly missed, I wanted clarification. For the second question, the key word would have been electrical charge. I did get this one. Okay, so possibly, but I would have to. Do we have time to kind of go back to the second one? Okay. Question, yes, the electrical charge at any given time between 2 points is referred to. So yes, we're looking at that electrical charge, like that electrical charge, and then you're looking at any given 2 points, because they're trying to get you to identify the get to the answer of volts. So yes, kind of getting those points. Yes, excellent question. I'm glad I went back around to it. Okay, I know this has been a longer chapter than normal, but I really wanted you guys to kind of really put your mindset, because you will be in the operating room and you never know what could happen. For those of you that are watching the archive, and for those of you who are here, kind of listen to what I'm asking, because you may see these again. What is one thing you will do to add to your own personal disaster plan after you've watched today's archive? How does being personally prepared make you a better, more reliable teammate in the operating room? Okay. Now, we talked about a lot. We are at week 7. If there is anything that you have questions on, you guys, please do not hesitate to reach out. I am here for you. Okay. What other questions do you have for this evening? Something does come up, let me know. With that, I want you guys to have a wonderful rest of your evening. Thank you guys for the participation and just being here and going through this with me. Have a good night, and I look forward to seeing everyone who can attend tomorrow's live session. Good night, everybody.